Welcome back to the deep dive. Today, we're really getting into something fundamental, something that touches every new family. We're exploring newborn feeding and nutrition. It's often surrounded by a lot of emotion, complex policies, and the science is always evolving.
Absolutely. It's that very first big challenge, isn't it? Beyond just keeping warm and breathing, this transition from fetus to neonate,
Mhm.
it's huge. Suddenly the baby isn't just passively getting nutrients.
Mhm.
They have to actively manage feeding, digestion, everything.
Right. And our focus today, really drilling down, comes from clinical sources. These are the kinds of things nurses, healthcare professionals need to master. It's about understanding the physiology, yes, but also how to provide that evidence-based, compassionate care right in those critical early days and weeks.
Exactly. It's that blend of hard science and practical support.
So, our mission for you, listener, is to cover all the bases. We're going deep into the newborn's physiology, the science behind breast milk itself, those big global health policies that shape hospital practices, and maybe most importantly, the actual hands-on skills nurses need to teach parents. How do you foster success, whether it's breastfeeding, bottle feeding, or some combination?
We want you to walk away with a really solid grasp of what optimal care and, crucially, optimal education look like in this field. We'll start with why breast milk is considered the standard scientifically, and then bridge that to the day-to-day reality of helping families figure it all out. It's that intersection that defines modern perinatal nursing.
Okay, so let's start with the foundation. Why all the emphasis on breastfeeding? There's a really strong scientific consensus here, isn't there?
Overwhelmingly so.
Right.
The evidence points to human milk as providing the most specifically tailored, functionally complete nutrition for human infants. It's often called the biological norm.
The gold standard.
That's the term, yeah. And it's because it's literally genetically matched to the human baby. But, it's so much more than just food. Our sources really stress how feeding ties into bonding, those first skin-to-skin moments, and how it sets a course for lifelong health.
That lifelong health piece is key. We're talking about impacts on the immune system, metabolism, things that play out for decades.
Absolutely. When we talk about breast milk, we're really talking about influencing a developmental trajectory.
So, if we dig into the specifics, the clinical data, like in Table 27.1 from our sources, lays out some pretty compelling benefits. Let's break those down, starting with the baby.
For the infant, the advantages are both protective and developmental. First off, there's a significant reduction in overall infant and child mortality rates. That's huge. Physiologically, breast milk actually speeds up the maturation of the gut, the entire GI tract,
How does it do that?
through specific growth factors and these complex sugars called human milk oligosaccharides, or HMOs. They essentially help build and mature the gut lining. This is especially critical for preterm infants, who are incredibly vulnerable.
Right. The sources specifically mention a lower risk of necrotizing enterocolitis NEC in preemies. That's a devastating condition. Why is human milk so protective there?
Well, NEC often involves inflammation and bacteria invading a fragile gut barrier. Human milk delivers immunological components, like secretory IgA, which literally coats the gut lining. And those HMOs, they act like prebiotics, feeding the good bacteria, which helps crowd out the bad guys. Plus, growth factors help seal the gut wall. It's like building a stronger shield.
That's fascinating. A structural shield. And the benefits go beyond the gut, right? Lower SIDS risk, reduced chances of childhood lymphoma, even type 1 and 2 diabetes later on.
Exactly. The link to metabolic diseases like diabetes is really interesting. It suggests breast milk helps program the infant's metabolic system correctly from the start, potentially lowering the risk of insulin resistance down the line. And there are noted cognitive benefits, too, often linked to the unique fats in breast milk, which we can get into.
Okay, let's pivot to the mother, the parent providing the milk. The benefits for them start immediately postpartum, don't they?
They do. Hormonally, it's driven by oxytocin. When the baby suckles, oxytocin is released. This causes the uterus to contract more effectively. That means faster uterine involution, the uterus shrinking back down, and critically, less risk of postpartum hemorrhage.
So a direct physical recovery benefit, and then longer term.
Longer term, we see significant preventative effects: reduced risk of breast and ovarian cancers, less cardiovascular disease, lower rates of type 2 diabetes. It seems the hormonal profile of lactation is protective.
Wow. And we shouldn't forget the psychological side.
Definitely not. While it can be challenging, the sources highlight that unique bonding experience. And when things are going well and support is there, it might offer some protection against perinatal mood disorders. It's a reciprocal relationship.
And finally, the societal angle. Convenience, cost.
Huge factors. Breast milk is always ready, no mixing, no bottles to wash initially, no cost for formula, less packaging waste. That convenience alone is a massive plus for families.
And healthcare costs overall.
They go down. Healthier babies mean fewer doctor visits, fewer hospitalizations, less time off work for parents. So supporting breastfeeding really does have broad economic benefits.
Given all this evidence, it makes sense that there are global policies to support and protect breastfeeding. The big one is the Baby Friendly Hospital Initiative, or BFHI.
Right, that's a joint UNICEF effort started back in '91. It was really a response to hospital practices that were, frankly, undermining breastfeeding. The goal was to transform hospitals into places that provide optimal clinical care for infant feeding.
So what does being baby-friendly actually mean for a hospital and the families there?
It means they adhere to specific standards. It generally leads to better staff skills and lactation support, more patient-centered care overall, definitely more mother-newborn contact, and a measurable drop in giving babies formula when there isn't a true medical need for it. Often it means getting rid of those central nurseries, keeping moms and babies together.
And that's driven by the 10 steps to successful breastfeeding. These are the practical things nurses are trained to do, right?
Exactly. It starts with policy having a written breastfeeding policy,
Sure.
training staff. But the steps that directly impact parents are things like step 4, immediate, uninterrupted skin-to-skin contact right after birth.
The golden hour.
Precisely, for at least an hour or until after the first feeding. This taps into the baby's innate reflexes and helps stabilize them, temperature, breathing, blood sugar.
It's physiology, not just a nice moment.
Absolutely. Then there's rooming in step 7, keeping mother and baby together, 204-7.
Why is that so important?
It allows the parent to learn the baby's early feeding cues. The rooting, hand-to-mouth movements, lip smacking. You want them to feed before the baby gets to the crying stage. Crying is a late sign of hunger.
And step 8, encouraging breastfeeding on demand. Responding to those cues, not watching the clock.
Yes, because milk supply is fundamentally a supply and demand system. Frequent, effective removal of milk signals a body to make more.
Okay, and then there's the potentially controversial one, step 9, avoiding artificial teats or pacifiers unless medically necessary.
Yeah, this one. It causes a lot of discussion. The concern is nibble confusion. The mechanics of sucking on a bottle teat or pacifier are very different from drawing milk from the breast. It can sometimes interfere with establishing a good, deep latch.
So the nurse's role here is crucial in explaining the why behind that recommendation, but also supporting the parent's situation.
Exactly. Education and support.
Yeah.
And speaking of protecting breastfeeding, we have to mention the International Code of Marketing of Breast Milk Substitutes, the WHO code from 1981.
This seems really important in shielding families from commercial pressures.
It's monumental. It aims to prevent aggressive or misleading formula marketing, especially where families might be vulnerable. The rules are strict. No direct advertising of formula to the public. No free samples given to parents. No promotion of formula within healthcare facilities.
And information given to healthcare workers.
It has to be purely scientific and factual. It must explicitly state the benefits of breastfeeding and the risks of artificial feeding. The idea is to keep the healthcare environment focused on the biological norm, free from commercial bias.
Understanding that code helps explain why hospital policies and nursing education are structured the way they are. It's framed by these global health directives.
Right, because the stakes are high. Suboptimal infant feeding is recognized as a major global public health issue.
Okay, we've got the policy landscape. Now let's dive deeper into the milk itself. You said it's more than just food, like a living organism.
That's a great way to think about it. It's dynamic, incredibly complex, and it actually changes based on the baby's needs, their age, their health, even the time of day. It's packed with immune factors, hormones, enzymes, growth factors, things formula just can't fully replicate because it's biologically active.
So let's talk about how it changes over time. The sources describe 3 stages of milk. The first one everyone hears about is colostrum, liquid gold.
Liquid gold, exactly. This is what the baby gets from birth up to about day 3 to 5. It looks different, thicker, stickier, often yellowish or even orange. And a key teaching point for nurses is managing expectations about volume. It's tiny, maybe 5 to 10 milliliters per feed, like a teaspoon or 2.
Which can worry parents, right? They think the baby isn't getting enough.
They do. But that small volume is perfect for the newborn's stomach, which is only about the size of a marble at first. And the function of colostrum isn't volume, it's protection and priming. It's often called the baby's first immunization. It's super concentrated in proteins, especially immunoglobulins like secretory IgA.
And what does that IgA do?
It literally coats the inside of the baby's gut, the mucosal lining. Think of it like painting the gut wall to prevent harmful bacteria and viruses from sticking and causing infections. It provides immediate, passive immunity.
Wow. Okay. And it does more than just immunity.
Oh, yes. It's also rich in lactose, which gives the baby energy and helps prevent low blood sugar. And critically, it has a laxative effect
Why is that important?
because it helps the baby pass meconium, that dark, sticky stool they have in utero. Getting the meconium out is really important for reducing bilirubin levels and therefore lowering the risk of jaundice. So colostrum is actively helping clear the baby's system.
Okay, so after those first few days of liquid gold, the milk changes.
Right. Then we move into transitional milk. This phase lasts from around day 5 up to about 2 weeks. This is usually when parents notice their milk coming in. Volume increases dramatically. The milk becomes thinner, lighter, yellow, or whitish. Composition shifts too. Protein levels start to decrease a bit, but fat and lactose levels shoot up. More calories for rapid growth.
And then finally, mature milk.
Mature milk arrives around 2 weeks postpartum and provides the stable nutritional profile going forward. It often looks thinner still, sometimes bluish-white, which again can surprise parents, but it's perfectly balanced with the right amounts of protein, fat, and carbohydrates, mainly lactose, for the baby's ongoing needs. By about a month, a mother might be producing 750, 800 milliliters a day.
But even within a single feeding of mature milk, it's not all the same, is it? This idea of foremilk versus hind milk seems crucial for nurses to explain.
Absolutely critical. This distinction directly impacts whether the baby feels full and grows well. Foremilk comes out first. It's more watery, lower in fat, makes up maybe 60% of the volume in that feed. Think of it as quenching the baby's thirst and providing quick energy from lactose and proteins.
But if the baby only gets foremilk, if they have a short feed or switch sides too soon,
Then they miss out on the hind milk. This comes later in the feed, maybe 10-20 minutes in, as the breast softens. It's much creamier, higher in fat, maybe only 5% of the volume, but packed with calories. This hind milk is what provides satiety, that feeling of fullness, and ensures good weight gain. Babies who only get foremilk can be fussy, seem hungry soon after feeding, and may not gain weight well even if they feed often.
so the nursing advice is key here. Encourage parents to let the baby finish the first breast thoroughly until it feels softer before offering the second side. Make sure they get that richer hind milk.
Spot on. It's about the quality of the feed, not just the frequency or duration sometimes. Understanding that helps parents troubleshoot.
Okay, let's zoom in on some of those unique components you mentioned. Protein and iron seem interesting. You said protein is actually quite low overall.
Yes, only about 0.9% in mature milk, which is much lower than cow's milk. But it's highly bioavailable and includes specialized functional proteins. One key one is lactoferrin.
And what makes lactoferrin special?
It's an iron-binding protein. Its superpower is grabbing onto free iron in the gut. Why does that matter? Because many harmful bacteria, like certain strains of E. coli, need free iron to grow and multiply. By locking up the iron, lactoferrin basically starves those bad bacteria, helping prevent infections like neonatal sepsis.
That's clever. And what about iron absorption itself? The difference is huge.
Staggering. Our sources say babies absorb about 50% of the iron from human milk, compared to only about 4% from typical cow's milk-based formula. Even if the formula is iron-fortified, the bioavailability is just completely different.
Wow. Okay, moving on to fats. You mentioned their role in brain development.
Yes, human milk is rich in long-chain polyunsaturated fatty acids, specifically the omega-3 DHA and the omega-6 AA. These are absolutely crucial building blocks for the baby's brain and retina. Formulas often add DHA and AA now, but the form and context in breast milk might allow for better utilization.
And cholesterol. Usually we think of cholesterol as bad, but not for babies.
Not at all. Human milk has significant amounts of cholesterol. It's essential for building cell membranes and, crucially, for laying down the myelin sheath around nerve fibers. Myelination is like insulating electrical wires. It allows nerve impulses to travel quickly and efficiently. It's fundamental for neurological development.
Makes sense. And carbohydrates. It's mostly lactose, right?
Primarily lactose, yes. And human milk has the highest lactose concentration of any mammal's milk. It provides about 40% of the baby's total energy needs. It also aids calcium absorption and is a key fuel source specifically for that rapidly growing brain. Thankfully, true lactose intolerance from birth is extremely rare.
So, with all these perfectly tailored nutrients, is there anything that does need supplementation?
Yes, the one standard recommendation is vitamin D. Breast milk typically doesn't contain enough vitamin D to meet the infant's needs, so the clinical guideline is 400 international units, IU, a vitamin D supplement daily for all breastfed babies, starting within the first few days of life until they're weaned or taking in enough from fortified foods or formula.
All right, this brings us squarely to the nurse's role on the ground, taking all this science and turning it into practical, effective teaching for parents who are often overwhelmed and sleep deprived. Let's start with a basic mechanism parents need to understand: the milk ejection reflex or the letdown.
Right, the MER. This is a fascinating neurohormonal loop. Baby suckles, nerves in the nipple send a signal up to the brain, specifically the hypothalamus. That tells the posterior pituitary gland to release oxytocin. Oxytocin travels in the blood back to the breast and makes tiny muscle cells around the milk sacs contract and squeeze the milk out into the ducts. That's the letdown.
But parents don't always feel it dramatically, right? So how does a nurse teach them to recognize the signs that it's happening?
Good point. Some mothers feel a tingling, warmth, or sudden fullness, but many don't, especially after the first few weeks. So we focus on objective signs. The number one sign is watching the baby. Their sucking pattern changes. It goes from short, quick, fluttery sucks that stimulate the reflex to a much slower, deeper, more rhythmic drawing pattern.
And you can hear it.
Often, yes. You hear audible swallowing, sometimes described as a soft ka or ah sound with each suck or two. That means milk is actually transferring. Other signs: the mother might suddenly feel thirsty or very relaxed, almost sleeky. That's the oxytocin effect again. Or milk might start dripping from the other breast.
And you mentioned oxytocin also affects the uterus.
It does.
Hmm.
Especially in the early days, the mother might feel uterine cramping or after pains during feeds. While uncomfortable, it's actually a positive sign the MER is working and helping her uterus contract back down. Nurses should explain that.
Okay, let's tackle probably the biggest hurdle: teaching and assessing effective latch. Our sources say a good latch is basically the most important part of breastfeeding success.
Absolutely. It dictates milk transfer, prevents nipple pain and damage, and ensures adequate breast stimulation for milk supply. The key message nurses stress is, it should be comfortable for the parent after maybe the first 10-15 seconds of initial pulling and driven by the baby.
So what's the technique? How does the nurse guide the parent?
It starts with positioning the baby well, tummy to the tummy, nose opposite the nipple. Then you elicit the rooting reflex. Gently stroke the baby's cheek or lip. Wait for the baby to open their mouth really wide like a big yawn. Then quickly bring the baby onto the breast, aiming the nipple towards the roof of their mouth. The goal is to get a big mouthful of breast tissue, not just the nipple tip.
What are the visual cues of a good latch that the nurse is looking for and teaching the parent to see?
You want to see the baby's lips flanged outward, turned out like fish lips, not tucked in. The chin should be pressed firmly into the breast, and the nose might just lightly touch or be clear. You should see more of the darker areola above the baby's top lip than below the bottom lip. And crucially, the baby's tongue should be cupped under the breast, doing the work.
And the red flags, signs of a poor latch that mean the parent should gently break the seal and try again.
Red flags include lips tucked or pursed, hearing clicking or smacking sounds, means the seal isn't tight, dimpling cheeks with sucking, and most importantly, persistent pain for the parent beyond that initial moment. Also, check the nipple shape after the feed. If it comes out looking flattened, creased, or shaped like a new lipstick tip, the latch was likely too shallow on the nipple itself.
And nurses often teach specific holds for the breast itself, right? Like the C hold.
Yes, using a C hold, thumb on top, fingers underneath, well back from the areola, or a U hold can help shape the breast slightly to make it easier for the baby to grasp deeply, especially in the early days. The key is supporting the breast, not pushing it into the baby's mouth. And always bring baby to the breast, not breast down to the baby.
Okay, latch is key. But the big question parents always have is my baby getting enough? Nurses need to give concrete ways to track this. Let's talk about the feeding norms and output assessment. First, frequency.
After the first day or so, the minimum baseline is 8 or more feedings in a 24-hour period. That often works out to feeding every 1 to 3 hours, sometimes more often, especially during growth spurts. Feed whenever the baby shows hunger cues.
Next up, weight. What's the normal pattern?
It's totally normal for babies to lose some weight initially. Typically, up to 7% of their birth weight is considered okay. Some sources might say up to 10% in certain circumstances, but 7% is a good general guide. The crucial part is they should stop losing by day 3-5 and be back up to their birth weight by about 10 days to 2 weeks, 2.5 weeks at the latest.
And once they regain that birth weight?
The expected gain is roughly half an ounce to 1 ounce per day. That's about 15-30 grams. Or around 5 to 7 ounces per week for the first few months. Consistent gain is key. Seeing a pediatrician for weight checks is important.
But day to day, before the next weight check, the diapers are the best indicator, right? How does the nurse explain what to expect in that first week?
The diaper count is the daily reassurance. It follows a predictable pattern. Day 1, at least one wet diaper and 1 or 2 stools, those first sticky black meconium stools.
Yeah.
Day 2, at least 2 wet diapers and maybe 2 stools, starting to transition. Day 3, at least 3 wet diapers and 3 stools becoming looser, maybe greenish.
And it keeps increasing. When do you hit the standard for good intake?
By day 7 and ongoing, the minimum expectation is at least 6 truly heavy wet diapers with pale yellow or clear urine in 24 hours. And for stools, at least 3 large, soft, seedy-looking mustard yellow stools per 24 hours. Seeing that specific breastfed poop is often a huge relief for parents.
Good visual cue. We also need to prepare them for growth spurts, those times when the baby seems suddenly ravenous.
Yes. Otherwise, parents panic and think their milk supply dried up overnight. Growth spurts are totally normal periods where the baby needs to feed much more frequently, maybe 15 times or more in 24 hours, often clustering feeds together. This increased demand signals the breast to ramp up production. They typically happen around 2-3 weeks, 6 weeks, 3 months, and 6 months. It's temporary, usually lasting just a few days.
Finally, let's touch on positioning. Getting comfortable and ensuring good alignment is vital. What are the main positions nurses teach?
There are several good ones. The cross-cradle hold is great initially because the parent supports the baby's neck and head with the opposite hand, giving lots of control. The standard cradle hold is similar, but the baby rests in the crook of the elbow on the same side as the breast they're feeding from. More relaxed once latch is established.
What about for moms who've had a C-section?
The football hold, or clutch hold, is often a lifesaver. The baby is tucked alongside the mother's body, supported by pillows, with their feet pointing towards her back. It keeps pressure off the incision. It's also great for mothers with large breasts or when nursing twins.
And for nighttime seeds.
Sideline can be fantastic. Mother and baby lie facing each other tummy to tummy. Needs careful positioning with pillows behind the mother's back and maybe between her knees, ensuring baby can't roll away or into soft bedding. And then there's biological nurturing or laid-back breastfeeding. The parent reclines comfortably, semi-upright, skin to skin, and lets the baby self-attach using their innate reflexes. Gravity helps.
So lots of options. But there's one rule that applies to all positions.
The absolute universal rule of alignment. The baby's ear, shoulder, and hip must be in a straight line. Their body should be turned towards the parent, tummy to tummy, not lying flat on their back with their head twisted to the side. If the neck is twisted, it's hard to swallow effectively. Straight alignment makes milk transfer much easier and more comfortable for the baby.
Okay, we need to address the times when breastfeeding isn't possible or when significant challenges pop up. The nurse's role remains crucial in providing safe, evidence-based care and support even when the plan changes. Let's start with the very rare contraindications where breast milk itself is forbidding.
And rare is the key word here. These are specific, inherited metabolic disorders that are usually picked up on newborn screening tests.
What are the main ones?
The classic example is classic galactosemia. These babies completely lack an enzyme needed to break down galactose, a sugar found in lactose. Since milk sugar, lactose, is made of glucose and galactose, any milk containing lactose, including breast milk, is dangerous. They need a special galactose-free formula right away.
Okay, what else?
Maple syrup urine disease, or MSUD. They can't break down certain amino acids, leucine, isoleucine, valine, so they need a formula free of those. And phenylketonuria, PAU. Babies can't metabolize the amino acid phenylalanine. They definitely need a special low phenylalanine formula. Our sources mention that sometimes, with very close monitoring by specialists, a small amount of breastfeeding might be combined with the formula, but the formula is primary.
So these are serious but thankfully uncommon. What about situations where breast milk is still best, but the baby might need temporary help or supplements?
This is much more common. It often involves babies who are physiologically stressed or immature and at high risk for hypoglycemia, low blood sugar. Think very premature infants, under 32 weeks or under 1,500 grams, or babies stressed from a difficult birth or whose mothers have diabetes. In these cases, the nurse might give expressed colostrum milk, donor milk, or sometimes temporary 5e glucose or formula supplementation until the mother supply is established and the baby is stable. The goal is still maximizing human milk.
Now, what about maternal contraindications? Situations where the mother shouldn't breastfeed?
There are only a few absolute contraindications. Active untreated tuberculosis in the mother is one. HIV infection in the mother, if safe, affordable, sustainable formula feeding is available. This guidance can vary globally based on risks. certain illicit drug use, like ongoing cocaine or methamphetamine use, and some medications like cytotoxic chemotherapy agents. The risk of passing the infection or drug to the baby outweighs the benefits.
But just as important as what isn't a reason to stop, right? Nurses need to combat misinformation here.
Absolutely. Common things that are generally considered safe for breastfeeding include hepatitis B or C infection in the mother, as long as the baby gets the Hep B vaccine series,
Yeah.
CMV infection, exposure to hepatitis A, even something like a single herpes lesion on the breast usually just means temporarily pumping and discarding from that side while feeding from the other until the lesion is healed. Most common maternal illnesses, like a cold or flu, are fine.
Good clarification. All right, let's move to common problems nurses help parents troubleshoot. First up, engorgement, that painful, rock-hard breast situation.
Yeah, engorgement is miserable, and the sources stress it's not normal physiological fullness. It's usually caused by a mismatch. Milk is coming in rapidly, days 3 to 5 typically, but isn't being removed effectively, maybe due to a poor latch or infrequent feeds. The breast gets swollen, hard, shiny, tender, and the nipple can flatten out, making latch even harder. Vicious cycle.
So what's the nursing advice?
It's a two-pronged approach. Before feeding, use moist warmth, a warm shower. Warm compresses for a few minutes to help the milk flow. Maybe hand express a little to soften the areola for latch. Between feedings, use cold packs. Bags of frozen peas work great for 15-20 minutes to reduce swelling and pain. And the absolute key, frequent effective milk removal, either by baby or pump.
Next, distinguishing a plugged duct from mastitis. How does a nurse explain the difference?
A plugged duct feels like a specific tender, hot, hard lump or wedge in the breast. Milk flow might be reduced from that area, but crucially, the mother feels generally well and has no fever. Mastitis is an actual infection of the breast tissue. You get the same painful lump or wedge, but it's often accompanied by redness, sometimes red streaks pointing away from the area, and the mother feels sick like she has the flu with fever, chills, body aches.
And the most important advice for both conditions.
Keep breastfeeding. Do not stop nursing, even if you have mastitis. Stopping suddenly will make it worse and could lead to an abscess. The treatment for both is frequent milk removal. Nurse often, starting on the affected side if possible. Use warmth before feeding, gentle massage towards the nipple during feeding, and rest. If it's mastitis, the parent also needs to see a doctor for likely antibiotics and pain relief, but keep that milk moving.
Okay, another common one, thrush, the yeast infection. Symptoms.
Thrush, candida, can affect both mother and baby. For the parent, the classic symptom is sudden onset of severe nipple pain, often shooting or burning, that can last throughout the feed and even afterwards. Nipples might look bright pink, red, shiny, sometimes flaky. For the baby, look for white patches inside the mouth, on the tongue, cheeks, roof of mouth that look like milk curds but don't wipe off easily. Baby might also be unusually fussy, gassy, or reluctant to feed.
And treatment requires treating both.
Yes, absolutely critical to treat both mother and baby simultaneously with antifungal medication, like nystatin suspension for baby, topical cream for mother, sometimes oral meds for mother too. And nurses must stress meticulous hygiene. Boil anything that goes in the baby's mouth, pacifiers, bottle nipples, and any pump parts that touch milk for 5–10 minutes daily during treatment to kill the yeast spores and prevent reinfection.
All right, finally, we have to acknowledge that some families will choose or need to bottle feed, using pumped milk or formula. The nurse's role here is teaching safe bottle and formula feeding practice.
Absolutely. The support and education responsibility doesn't end if breastfeeding isn't the method. Safety first. Teach parents to hold the baby close, semi-upright, never flat on their back during feeds, and the cardinal rule, never, ever prop the bottle. It's a serious choking hazard, increases risk of ear infections, and bypasses satiety cues.
And using slow-flow nipples is usually recommended.
Yes, especially initially. And the technique we really encourage now is pace bottle feeding.
How does that work? It's meant to mimic breastfeeding more closely.
Exactly. It gives the baby more control over the flow and pace, helping prevent overfeeding and promoting recognition of fullness cues. You hold the bottle mostly horizontal, just tipped enough so milk fills the nipple tip, not the whole thing. Let the baby draw the milk in actively. When the baby naturally pauses their sucking rhythm, which they do during breastfeeding too, you can gently tip the bottle down slightly, or even remove the nipple from their mouth for a moment, letting them catch their breath before they cue to continue.
So the baby leads, not the parent just pouring milk in. And the feed ends when the baby seems done, not necessarily when the bottle's empty.
Precisely. Respect the baby's signals of being full, turning away, relaxing, falling asleep.
For parents using pumped human milk, storage guidelines are vital safety information. What are the basics?
Okay, optimally. At room temperature, cool room, like 60, 77 degrees air. Freshly expressed milk is good for about 3-4 hours. In the refrigerator, at about 39 degrees foot or 4 degrees C, it's optimal for 72 hours, 3 days. Though some guidelines say up to 5-8 days under very clean conditions might be acceptable. In a standard freezer compartment within a fridge, maybe 2 weeks. In a separate door freezer, like a chest or upright, 6 months is optimal, potentially up to 12 months is acceptable. And the big no-no for warming: never microwave breast milk. It destroys some of the valuable immune components and creates dangerous hot spots that can burn the baby's mouth. Thaw frozen milk slowly in the fridge overnight, or hold it under warm running water, or place it in a container of warm, not hot water. Swirl gently to mix the fat back in. Don't shake vigorously.
Finally, as families prepare for discharge, what's the last piece of the nursing care puzzle?
Providing community support resources. The hospital stay is short. Parents need ongoing support. Nurses should provide contact information for certified lactation consultants, IBCLCs, for complex issues, public health nurses who can do home visits, peer support groups like Lolesha League, local hospital breastfeeding clinics or support centers, and reliable websites. That continuity of care is crucial. Hashtag tag outro.
Wow, okay. We've covered a huge amount of ground today, from the high-level WHO policies and the intricate science of lactoferrin and DHA, all the way down to the nitty-gritty of teaching a good latch, interpreting diaper output, and mastering paced bottle feeding.
I think the central theme that emerges is that dual role of the nurse, isn't it? They have to be a sharp clinical assessor, monitoring the baby's transition, weight, hydration, but they also have to be this incredibly skilled educator and communicator, empowering parents with the knowledge and the practical tools they need to feed their baby successfully and confidently, whatever method they use.
Right. And our source material, while clearly presenting the strong scientific case for human milk as the biological norm, also finishes by emphasizing something critical: that the nurse's ultimate role, after providing all the best practice information, is to support parents non-judgmentally in the feeding choices they make.
And that right there creates a real tension sometimes in practice, doesn't it? You have these strong policies, like the Baby-Friendly Initiative, pushing for specific practices, but you also have this core ethical commitment to patient autonomy and informed choice.
So the provocative thought we want to leave you with today is this: when a parent has been fully informed about the evidence, about the recommendations, but then makes a choice that diverges from that gold standard, maybe they choose formula from the start or decide against rooming in, what does true, unbiased, informed support actually look like from the nurse in that moment?
How does a nurse navigate that space between upholding best practice policies and genuinely supporting the family's decision without conveying judgment, implied or otherwise? What are the concrete actions, the specific words that embody that impartial support when the chosen path isn't the one promoted by the guidelines?
A really challenging question about the realities of patient-centered care in a world of clinical standards. Something to think about. Thank you for joining us on the Deep Dive.